Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and today we are continuing on with our Women's Health Month, and we are going to be talking about Stop the Leak, women's bladder issues. I have Alexis Chesrow. She is a physician with Arizona Urology Specialists with us today. You may be watching us online. We also have an in-person audience. Dr. Chesrow is board certified with the American Board of Urology in both urology and female pelvic medicine and reconstructive surgery. She focuses her practice on the correction of complicated incontinence and pelvic organ prolapse in a female patient. And she also has an expertise in neurourology and worked to develop a comprehensive bladder program for patients with spinal cord injuries and neurological disorders. Please, if you have any questions for Dr. Chesrow, leave those for us in the comments and we will address those at the end of the presentation. So I want to welcome you here, Dr. Chesrow.
Thank you for having me. And apologize for the scrubs. I was in surgery today. So basically what all those credentials mean, and I'll repeat them because I was talking to those people who are here with me, is I'm a urologist, but I'm also fellowship trained in what we call urogynecology. And that is pelvic health and reconstruction in women for incontinence and prolapse, pelvic pain, and the whole gamut of disorders that women can have as they age. Or as I like to say, I'm just a very, very fancy plumber for women. And there are so many more things we can do. So right now we're just going to go over some basic types of incontinence and some of the simple treatments to give you an idea of what's out there, and then we'll go from there. Okay. So urinary incontinence is when you leak urine. I know it seems simple, but sometimes people are surprised. There's also fecal incontinence as well, and we do have treatments for both modalities. A lot of times as a urogynecologist, I will coordinate with a gastroenterologist, a colorectal surgeon, pelvic floor physical therapist, and we'll do a multidisciplinary approach because we like to address everything that lives in the pelvis, okay? I start off by saying incontinence is so common, women don't realize that it's 18 million women. Men and women in the United States spend more money on incontinence products than they do heart disease, to put it in perspective. But there's a huge advertising campaign to really say, hey, wearing pads is normal. You switch your menstrual pads right into your incontinence pads and just keep buying these products and on you go. And we understand years ago, some of the surgeries were pretty robust and had high failure rates. The medications had lots of side effects. That's just not the case nowadays. We have so many lovely modalities that we can try for our patients that we can really get the majority of women markedly improved. Okay, but there's more than one type of incontinence. So just because you see leakage on the outside, there can be more than one reason you're leaking on the inside. So one, as we get older, our bladder gets smaller. We all revert back to a toddler's bladder. It's great. So your bladder gets smaller, and then it has spasms, little Charlie horses. Well, the bladder's a ball. If it gets smaller, guess where that urine wants to go? Out. That's that sense of I can't make it to the washroom in time. I put the key in the door and my bladder it's go time. You get out of bed at night and you feel like it's just going to come out before you get to the bathroom. So overactive bladder is a normal part of aging where we revert back to a bladder that functions like a toddler's bladder because it basically says, hey, if there's urine in there, we get it out. We lose our adult control of the bladder and it reverts back to spasming and just kicking the urine out all the time. Stress incontinence is a leaky valve. So this is your bladder. You have a valve. So when you cough and you push on that valve should tighten so you don't leak. Age, genetics, childbirth, estrogen changes make that valve loose. So when you cough, instead of tightening it, pops open, urine comes out. That's not a bladder that's too spastic that I need to relax and make the bladder function like an adult. That's a leaky valve. I have to tighten the valve. So those are the two main plumbing issues, overactive bladder and a leaky valve we can address. And there's things we can do to tighten the valve as well. Mixed incontinence is just because it can be super fun. You can actually have both types of incontinence. And then usually we'll work you up and we'll say, hey, look, your bigger issue is incontinence type 1. We really should fix this first, and then we'll reassess. Other women need both fixed. So I often tell women, if you have 2 holes in a bucket, I got to fix both before that bucket stops leaking. So a lot of times women will come to me from another provider and they're still leaking because they've only fixed one type of incontinence and forgot you can have 2. So I say, if you've tried other therapies, don't be upset if they haven't worked for you. You may just have a second type of incontinence as well, and you need both fixed in order to be dry. And that is something that we really can work through pretty easily. Okay. So again, about a third of women will have urge incontinence isolated in their life. The older you get, the more common it gets. I also tell people, though, children have overactive bladder, and so do young adults. They often just get missed. So if you have one of those younger friends who's always doing the potty dance, can never make it to the bathroom, they can have early onset overactive bladder. Stress incontinence, about 50% of women will develop in their lifetime. It is related to childbirth, but it can be without childbirth as well. I used to take care of a convent and take care of all the nuns who had prolapse and incontinence as well. So there's a strong genetic component as well. At least a third of women will get both. And those are the women who often come in frustrated because they've tried one therapy. But we really just need to treat both, and then we can get you markedly better. Overall, I say, my goal if you see me would be the minimum I would like to get you 50% more dry. Everyone wants to be 100% dry, but I will tell you a 50% improvement is a marked quality of life, and that's what we start with as our goal, and then we go from there. Okay. So, urge urinary incontinence, we're going to circle back to this one. This is the overactive bladder. This is when we all revert to a toddler's bladder. Our bladder holds less, gets smaller, and has little Charlie horses or spasms. So they usually say, if you're going more than 8 times a day, that's about when most people start to get uncomfortable. But it's really individual. If you were one of those who had a bladder of steel and only went 3 times a day and now you're going 6, you're not so happy about it. I have other people who go 10 times a day, but it's Tucson and we drink a lot of water and they're comfortable with that. So really, I stress to women, the main thing is if you are unhappy with your bladder, that is a change for you. And so that's why we say, hey, 8 times a day, but really it's unique to the patient and we customize to you, okay? Stress incontinence, we say, can you jump on a trampoline? And if you're like, oh, absolutely not, that's the leaky valve. If you cough, sneeze, lift something heavy, sudden movements, that's that valve that just pops open because it can no longer close. So stress incontinence is often broken down into 2 types, and that helps us choose what type of treatment we can do to tighten up that leaky valve. So sometimes the support to the urethra has just gone away and your urethra moves around too much and it's not supported. That's called hypermobility. Other times, due to genetics and age, the urethra gets really rigid and it won't close and form a seal. And that seal is really important. Your urethra actually shouldn't be an open tube. It should stick together like 2 wet pieces of plastic, and that seal is what really helps keep you dry. So a lot of times surgery is not to really tighten up the valve and close it. That's what we used to do. And those had various outcomes. Really now we're trying to reestablish the inside of the urethra to form that seal so you can cough and not leak. Okay, now we're going to go over kind of an overview of treatments. Once, there's, in my group, there's actually 3 of us who specialize in female urology and incontinence. It's Dr. Barmatz, Dr. Claudia, and me, Dr. Chesrow. So we recognize in Tucson and nationwide, there's a huge need for appropriate female-centered incontinence treatment, and we're really thrilled that we have so many providers with those options. So we're going to go over treatment, but just keep in mind, once we meet you, we customize to your specific bladder and pelvic needs. So, but I also say, one thing I talk about is and I touched on before, there's a huge advertising push that pads are an appropriate treatment. And they are. They're great. They do help keep you dry. And if a lot of women just don't have either the health or the time for surgery or don't want to take other medication, they may have other health issues where medication and surgery are not options, then pads are great. And we would still see you if you're in pads, because sometimes pads can be irritating. They can lead to urinary tract infections. And we can optimize it so that if pads are what you need, we can make them more comfortable for you and make sure they don't chafe your skin. You're not getting UTIs, you're not getting yeast infections from the moisture on your skin. So even if you're still a pad user, it's sometimes worth it to come in and just have us do what I say is a little housekeeping to make sure you're as comfortable as you can be. Keep in mind, though, there is a huge advertising push for pads, and that's all you need, and we do have a lot of treatments. So we always start with first-line treatments, and that is just lifestyle changes. We'll see how much you're drinking, we'll see how much your bladder holds, or see if you're having urinary tract infections that may need to be treated. Urinary tract infections can feel very different when you're postmenopausal than they did when you were younger. A lot of times they can be silent in the background. We also check your vaginal estrogen status. That is called genitourinary syndrome of menopause. Lack of estrogen in the vaginal canal in up to 50% of women can lead to overactive bladder. And we're very lucky that vaginal estrogen replacement, where you put the cream or the hormone only in the vaginal canal, has no risk of cancer. It doesn't cause breast cancer, heart disease, or stroke. It's a topical. So if you put it in the vagina, it stays there, and it is the number one way to prevent UTIs because it restores your natural immunity against UTIs. And in 50% of my women, it really makes their bladder function better. So a lot of times, even though you come to see me for incontinence, we'll have a vaginal hormone talk because at least 50% of my women won't need me to do anything else. If I just correct their vaginal hormones and prevent UTIs, they really have a much better bladder than they thought they did. Physical therapy is a wonderful option. So there are actually dedicated pelvic floor physical therapists. They're PhDs of the physical therapy world, and they do wonders with your pelvic health. It's not just Kegel exercises, even though that's a good part of it. They strengthen their muscles that need to be strengthened. They relax the muscles that have gotten contracted over time. So you may be contracted when you should be relaxing to urinate, and there's a whole process of how our whole pelvis should work. But our pelvis keeps us upright, and we've been walking on it for years. So over time, just like you can get a stiff neck or stiff shoulder, you can get contracted muscles in your pelvis, and pelvic floor physical therapy can do wonders for helping with overactive bladder and stress incontinence. For a lot of my women, it's a great first option, okay? Otherwise, the real main treatment for overactive bladder is medication. And I caution my women, there's really two classes of medication out there. The older medication, which are called anticholinergics. And those are those ads you see on TV for the gotta go right now medication. A lot of you may have already tried a medication called oxybutynin, Detrol, Vesicare. I caution my women with those medications because they can have a significant number of side effects. I rarely or just don't use them because they can cause dry mouth, dry eyes, constipation. But the biggest problem is they cause memory issues, up to 10 years of mental aging. So anticholinergic bladder medication, they're still prescribed, but there's pretty good warning. If you're over about 50, we really don't recommend them anymore because there's 2.5 medications on the market that don't cause the memory side effects. And those are called the beta agonists. They work on a different receptor in the bladder and they don't cause the memory issues. And that's Myrbetriq or Mirabegron. You may have seen a TV ad for that, or a newer medication called Gemtesa. The main side effect of Myrbetriq, sometimes in very rare patients, it can cause a little high blood pressure. Rarely, it's not the best if you have very severe heart disease. Gemtesa is a little safer on both those impacts. So I say there's 2.5 medications. There is one anticholinergic medication, those old medications that can cause memory issues, that doesn't, and it's called trospium or Sanctura. And it will still cause dry mouth, dry eyes, and constipation, but it doesn't impact your memory. So I have 3 overactive bladder medications that I know won't impact my patient's memory. I don't use the other ones, but I caution my patients they're still available, and sometimes they're the generics. But what we do is we just write a prior authorization and we say, no, we don't want our patients to have memory issues. These medications aren't appropriate if you're over a certain age, so no thank you. And then the insurance companies usually fight us a little bit, but we usually win. Okay. All right. So medication, first line, helps many women, but not everybody wants to stay on a pill the rest of their life. You can have side effects, and medication doesn't work for everybody. So if you have overactive bladder, resistant to medication, we have 3 other things we can do. We can, 1, Botox, just like for your face. We can inject it into the bladder, and instead of making that bladder spasm, it relaxes. You get it twice a year. We can do it in the office. It's very easy. It's no worse than a blood draw. Most of my women are chit-chatting with me while I do it. I put a little numbing gel in the bladder, and it's pretty quick and easy. And if it works for you, my patients love it. Botox is inappropriate for all types of bladders. So we can, instead of using Botox to relax the bladder, we can talk to the nerves that go to the bladder and tell the bladder to function better. There's 2 ways we can do that. 1, we can give you a bladder pacemaker. Just like you have a pacemaker for the heart, we can give you a bladder pacemaker. It sits in your tush, and it talks to the nerves that talks to the bladder and tells the bladder to act like an adult again. Remember that toddler bladder I talked about? It sends the, hey bladder, act like an adult, hold more, don't be so spastic. There is a milder version of the bladder pacemaker. The nerve behind your ankle runs all the way up your leg like a telephone line and connects to those nerves in your back that talk to the bladder. So we actually have an FDA approved medical acupuncture. I say medical acupuncture because most people know what acupuncture is. We literally put an acupuncture needle in your ankle, hook you up to what looks like a battery, and we run electricity up to your leg to talk to that bladder center. And that's another way to send a message through your nerves and tell your bladder to act like an adult, which is what we wanted to do so you'd be more comfortable. So that we do in the office. So if you live close to our office, you love the medical acupuncture, you pop in once a week. And if it works for you, then we push you out to once a month. And most women just incorporate it in their daily errands. And if you don't live close to my office, then it's not really a viable long-term therapy. And that's why the permanent bladder pacemaker or Botox really means no one wants to see us that often sometimes. So we totally understand that. So we don't expect you to come monthly for the rest of your life. But medical acupuncture can be easily done, and it causes no side effects, doesn't interfere with medication. So for some of our women who have other health concerns going on, it's a great short-term option. Okay. All right, now we're going to talk about the leaky valve. So you have the overactive bladder. We just need to tell that bladder to act like an adult and hold more. But if the valve is leaking, that means when you get up out of a chair, you cough, you sneeze, that valve pops open. So again, pelvic floor physical therapy, that's those Kegel exercises, is a great way to strengthen that valve. Now, we all get told to do Kegels on our own. It's really hard to do them on your own. We all squeeze the wrong muscles because if the muscle is so weak, guess what? Your body's going to squeeze the stronger ones around it, and it's really hard to exercise that. That is why seeing a pelvic floor physical therapist is so important. They can do some biofeedback and put a bunch of sensors on you and really make sure, just like working out with a personal trainer, that you're squeezing the correct muscle, and it's really worthwhile. I send a lot of my women with mild stress incontinence for pelvic floor therapy. If they get improved, then I just say, when it wears off, let me know, and we'll send you back. And a lot of my women go back every year or 2 until it just stops working, and then they come back to me to do more. And that's a great option. It's not enough for everybody, all right? If you have really severe incontinence, I say usually it'll get you about 25, 50% better. But if your incontinence is very severe, it's not going to be enough to get you as dry as you would like to be. So, a couple of options. And fixing the valve usually is surgery, okay? But, and you may have seen these at Walgreens, and I'll go into them. We do have rings we can put in the vagina. And what it does is if this is your urethra that's moving around, the ring sits underneath it, so when you cough or sneeze, it's supported. And these are called pessaries, but they're a specific type of pessary called an incontinence pessary. Not everybody can fit a pessary, just like not everybody can fit the same pair of shoes. So if I can find an incontinence pessary that fits you, you won't even know it's there. It only has to be taken out and cleaned a couple times a year. You usually can do that on yourself. You think I'm a magician, okay? If I can find one that fits and it's comfortable, 75% of the time, it's just not going to fit you so well. And then you kind of wonder what's wrong with me and why I made you try this weird vaginal ring thing. And I freely admit that, okay? But we do a fitting in the office and we just see. And if you're interested in it, it's a good option. It's called the Poise Impressa. It's something that you'll see at Walgreens, and it's for leakage. And it's a little insert you put in the vagina, and it's supposed to press on the valve. Theoretically, they work. But really, they're like a rough piece of cardboard. So unless you are really good at putting them in and out, it's usually a pretty bad experience for my patient. If I have a patient who's really motivated to use them, they have fit kits. I just tell you to come to my office with the fit kit and we'll try them together. So if you get it in there, I can help you get it out because they're sometimes really abrasive and not always the best experience. But for my patients who have an event and they want to use something short term, just, like when they go play golf or when they go hiking, but they're fine the rest of the time, that is something they can easily pop in just for 8 hours and take out. And then I just say, come in, let me show you how to use it so we make sure you're using it appropriately and don't, kind of scratch up the vaginal canal. All right, so those are things we can do in the office. But really the main surgery for stress incontinence is called a sling. And what a sling is, it's a hammock that sits under the urethra. Let's see if I can not unplug the computer, maybe grab a cord here to show you. So this is your urethra. A sling is literally a hammock. It just goes under like this, okay? So when you cough or sneeze, it catches it. Back in the day, they used to pull slings super tight so you would never leak a drop. Well, if you pull a sling super tight, guess what? You're not gonna pee very well either. So we now know we don't have to do that. We can place them gently and just provide support. If you remember, I said, we just need the inside of the urethra to stick together. We don't have to tie it shut. And that's why those old surgeries, a lot of women were like, I don't leak anymore, but man, I'm not comfortable. I can barely pee. I'd have catheter afterwards. They were pretty aggressive. Now we know better that we really can just appropriately tension them, and slings are great, okay? Now, slings come in several forms, and one of the main ones is synthetic mesh. And I always tell my patients that is 100% the same synthetic mesh that you saw those lawsuits about. And if we get to the point where synthetic mesh is appropriate for you, I will explain those lawsuits. And I usually start off by saying, really, synthetic mesh is no different than anything else artificial we put in the body. Pacemakers, artificial hips, artificial knees, heart valves. Anytime you put something synthetic in the body, there's a risk it can get infected and not work. The reason we had so much trouble with synthetic mesh vaginally, it was bigger pieces of mesh designed to lift up bladders that had dropped. And really, when it first came out, it was kind of the Wild West and everybody was putting it in without appropriate training. And so doctors went to the FDA and said, hey, look, there needs to be more regulation. Really, only people should be putting this in who know what they're doing and know how to fix it. You would think that would be obvious, but. So the FDA put a warning and said, hey, look, don't put mesh in people unless you know how to do it and know how to fix it if you put it in wrong. And then lawsuits got involved. And so what I tell my women who have prolapse, the lawsuits stopped a lot of good research and new products coming out that were delightful, gentle. And what they did was they based the lawsuits off the older products. And I always say, when people first started learning how to do this, they weren't so good at it. You don't want your dermatologist doing your hip surgery. So nowadays there's people who are fellowship trained like me, and I actually specialize in post-mesh complications, and I still use synthetic slings. They're one of my main go-tos. So I always tell women the lawsuits were never about slings. It was only about the bigger pieces of mesh to lift up the bladder. But I'm really honest, it's 100% the same mesh. So it's really splitting hairs. And I say we put synthetic devices in men all the time, and they've never been taken off the market. All they do is do better research and make them better. So really what the FDA should have done is done more research and allowed us to develop better products for women. And we think they'll circle back to that in about 5 years, but everyone got scared and they just yanked all the products off the market. Luckily, we still have slings. There was a few of us who were going to hoard them just so we could put them into our other colleagues in our own garages if they were going to go off the market. So that should tell you that they're really pretty good. If other doctors are like, all right, just keep one. Yeah, you can put it in the living room. So slings are great if you need one. They have lovely outcomes. They get women dry. But not everybody is appropriate for a sling. Some women are diabetics and they don't heal well. They've had pelvic radiation. They have very thin tissue. Then putting a synthetic in is not a good idea. And then instead of supporting the urethra underneath with a hammock, I can go in the urethra and inject a gel to tighten it up and form that seal. And those are injectable bulking agents. And there's a couple on the market, and really they're no downtime. It's no worse than a blood draw. They're not as durable as permanent as a sling. They last from 1 to 3 years really, but we can repeat the injection where they were off. So for some of my women who do not want to have a surgery, are busy at work, don't have time to take time off work, an injectable agent to get you dry, is a lovely option, and they do work great. Some of them we do in the office, and they don't even require anesthetic or numbing medication. Is really no worse than a blood draw. So there's 3 different ones on the market, and if at your workup at that point that becomes an option, it's really a great option for many of my women. With slings, just so you know, some of our women just aren't appropriate for mesh. We can make slings out of other materials. And one of them is we can actually take a piece of you from your abdomen or your leg and make a sling out of your own piece of your own tissue. And it's called an autologous sling. Those work great. They're a little bit more of an involved surgery because we're making a bigger incision and taking out a strip of your fascia. But for some women who've had serious stress incontinence, have failed other procedures, taking a piece of your own tissue can really fix the urethra. So I always tell my women, slings can come in different types too. So that goes back to how we customize the procedure we do to the patient who's in front of us. So it's not one size fits all. Okay. So the mesh slings have been around, oh goodness, 1998. So quite some time. We have over 30, 40 years of experience in putting them in. And the risk of having a problem with the mesh and a mesh sling with someone with appropriate training is about 5%, which is the risk of having a problem, bleeding, infection, need for something else to be done with pretty much any surgery. So we say the risk isn't really more than any atypical gallbladder, hernia repair, appendectomy when you take a sling. Okay. So that shows you what it is. It's a little hammock. It goes under the urethra, and it sits behind the pubic bone. There's no sutures holding it in place. It's just a little piece of Velcro. It kind of sticks in there on its own. All right. And that is the basics. So just keep in mind, there's more than one type of incontinence. Some women have both types of incontinence. And depending on the type of incontinence you have, we can discuss unique procedures. But I always remind women, just because your friend had a sling doesn't mean it might work for you, because you could have overactive bladder. Just because your friend got Botox doesn't mean the Botox will work for you, because you may not have overactive bladder. You could have stress incontinence. So the take-home message is really about seeing someone who can evaluate your whole pelvic health and build a customized plan to your needs and your goals, because everyone has different goals about how dry they want to be. Okay? All right, nice to speak to you all, and happy to take any questions you may have.
So Maya will ask mine first.
Perfect.
So Dr. Chesrow, so my question is, should you go just in case, or does that cause more issues with incontinence?
So that's the age-old question. Should we hold our bladders or should we not? So in general, you should go when you feel like you have to go, and don't go if you don't. You do not need to sit there and squeeze every last drop out. We actually don't empty our bladders 100%. We leave about a couple ounces behind, which is, about this much liquid, surprisingly. So if you sit there and try and push, you can always get some more out. You don't actually need to. So I say, go when you need to go. If you don't feel like you need to go, you're okay. But if you come see us, we typically have you do a bladder diary, and that lets us know how small, medium, or large your bladder is, and really lets me know if you're avoiding appropriately or if we need to adjust some habits. So we always kind of check your habits when you come in and just see if we should probably adjust that, or no, you're fine.
That's great. And I'm going to go ahead and turn it over to your in-person audience, and I'll let you know if we have other questions come up online.
Thank you, Ryan. All right. Anything I can add? Yeah, go ahead.
Okay, question on the bulking agent.
Yes.
If you have a tendency for kidney stones and pass it, through the bladder and then out, how is that bulking agent and the narrowing going to affect?
So typically kidney stones are small enough that they shouldn't get caught in the urethra. Once they get through the tube connecting the kidney to the bladder, you're usually home free. It's because the tube connecting the kidney to the bladder is much, much smaller than the urethra. So if they can make it through that tube, you should be able to pee it out. Rarely, and I mean rarely, are you able to pass something really big through this tube and it'll get stuck in the urethra. And usually it's only men that it gets stuck in, because it gets stuck in their prostate. So usually it's not something we really have much concern about. Okay. And the bulking agent moves, so it doesn't close it. It's a seal. So when you go to urinate, it opens back up. And then forms that seal again.
Okay, because having a stone that diminishes the tube between the kidney and the bladder,
Yep, the ureter, yep.
that was my concern, because I had it happen where it narrowed it and it looked kinked on a CT scan, and I still have one. I didn't know how that bulking would affect.
If it can get through that tube, you'll be able, I say once the stone is in the bladder, you're home free.
Okay.
Most of the time. Majority of the time.
Yeah, thanks.
I say nothing's an absolute, trust me, I've seen most things once, but if I've seen it once, it means it really is not very common. Okay. Anyone?
If a MRI and an ultrasound shows a healthy bladder, why might you be passing blood?
Blood in the bladder can be from a whole variety of things, and that's called hematuria, blood in the urine workup. And blood in the urine workup usually involves imaging of the kidneys, but the bladder doesn't show up on imaging. So just like if you have blood in your stool, you need a colonoscopy to look at the lining. When you have blood in the urine, you need a cystoscopy, a camera in the bladder to look at the lining. And we also want to make sure you don't have a mass or a polyp in the kidney, passing a stone. You can get polyps in the bladder, like you can get polyps in your colon, or a lot of times lack of estrogen and UTIs can lead to blood in the urine as well. So if you ever see blood in the urine, you do need a full workup. It doesn't have to be with a female specialist, it can be with any urologist. But yeah, it's a two-part thing. We x-ray the kidneys to take a look at them, and then we put a camera in your bladder to look at the lining directly and check for UTIs.
Where is your office?
Oh, it's right across the street. So
It's right here.
Yep, Arizona Urology Associates of Arizona. We just got bought out by United, so our name changed. But we have offices right near Northwest Hospital and right near TMC.
Okay.
Yeah, we're one of the larger urology groups in town.
Yeah.
So now we changed our name to Arizona Urologic Specialists. I know, it's just various different combinations of specialists, Arizona, Southwest Urology. If you Google any of that, you'll find us. And then,
Dr. Chesrow, I've got a question here. I have somebody who asked many times when they tighten up to hold till they go to the bathroom, till they get to the bathroom, they begin to pee. Is that a valve issue?
so if you're trying to make it to the bathroom and you can't get there in time, that is typically overactive bladder. That is your bladder going close enough and it has that little spasm like a toddler's bladder and just goes, nope, close enough. And you will say, but we're not close enough. And your bladder says, don't care. And that is the hallmark of overactive bladder. You feel like you start peeing, you're really close to the toilet, but you don't quite make it. And that's when I say your bladder is no longer a team player. So I always tell people, they say, hey, at what point should I fix my incontinence? How bad does it have to be before I should see someone? And I say that's a very personal decision. So if your incontinence bothers you less than seeing me does, ignore me. You don't need me yet. But if going to the doctor bothers you less than your incontinence does, welcome aboard. Because if it bothers you enough, then it's worth it to come in. Okay? And if you're only leaking a few drops and you're wearing a liner and you're like, I don't want another doctor visit, wait, it's not going to hurt you. But when it's interfering with you doing the parts of your day that you enjoy, that's the appropriate time to have us come do something. So I said, yes.
Has solar-therapy been useful for your patients, or have they not found it worthwhile to continue it?
So Vesicare, Solifessin, is one of the older anticholinergic medication. It can have dry mouth, dry eyes, constipation, and some memory issues. It is a very effective drug for some people and does help. I generally say if it's working, you're not having side effects, you're more than welcome to stay on it. But usually if my patients come to see me, I try and shift them to the medication with less side effects long term, just because I don't like the potential for memory issues. Yeah.
Is the vaginal hormone, is that determined like through the old Pap tests? where they take a scraping?
So, no, what we do for the vaginal hormones is, one, we just look at your tissue. And if it is thinned out and pale, we can say that, hey, look, you have signs of atrophy of the vaginal lining, of the lining of the vaginal canal. And really, we just look and we say, yep, all right, it's there. Sometimes we check your vaginal pH. It's just like, it looks like a pull strip. And normal vaginal pH should be less than 5, really 4.5. And so if you're higher than that, your natural bacteria has moved out. You don't have your good probiotics anymore. The tissue will get thinner. So the vaginal estrogen corrects the pH level. Your natural probiotics move back in. Everything gets more comfortable. About 50% of women, the bladder will improve. And it is the best way to prevent postmenopausal UTIs.
Dr. Chesrow, does untreated OAB damage the kidneys?
So very rarely. I pause. I specialize in neurourology as well. So I'll see all the patients with Parkinson's, multiple sclerosis, who've had strokes that have disrupted the whole neuro axis to the bladder. So sometimes in patients with spinal cords, the bladder can get so overactive, it'll squeeze urine back up to the kidneys. That's pretty rare in general population, okay? So other than in my spinal cord injured patients, really, overactive bladder, if the bladder's going to squeeze, it rarely goes up, it shoots out. So it can't hurt the kidney if it's leaking out into your pad, it's still flowing downstream. It's pretty rare for a bladder to be so spastic. There has to be a blockage of some type that would shoot it back up to the kidneys. But if you've had a sling and they didn't treat your overactive bladder, or you have a dropped bladder, and when it spasms, if it can't go out, then it will go up. But that's very uncommon. Typically, you just leak and it does not hurt the kidneys.
Okay. And I had a couple more questions that came in. Is genetic enablix one that causes memory issues?
Pardon me?
Is genetic enablix one that causes memory issues?
So Enablex is an anticholinergic medication, so it does have the potential to cause some memory issues, yes.
Okay. And can you have a UTI and not know it? And are the over-the-counter UTI tests accurate?
All right, so that's an excellent question. So it is normal to have bacteria in your urine when you are postmenopausal. So just because the test is positive doesn't mean that bacteria needs to be treated. We are covered in bacteria from head to toe. So if I swab my hand, I will grow bacteria and the test will show bacteria, but I don't have an infection. So if I was to test the urine of everyone in this room, the majority of you would have bacteria floating in your urine, minding its own business, and I would not recommend antibiotics, even though the urine culture would say, hey, there's a potential urinary tract infection. We found E. coli or other bacteria. That bacteria is normal, it should be there. As long as it's floating in the bladder, minding its own business, no antibiotics. It's only when it sticks to the bladder wall and makes you feel bad, that's when you should be treated. So it's a really common thing. I see someone goes through their yearly physical, they give a urine specimen, the primary care doctor calls them back a couple weeks later, hey, did you know you have a UTI? I'm sending in antibiotics. And the patient will be like, yeah, I had no symptoms, but every time I go and they test my urine, there's some bacteria there. That is normal. Vaginal estrogen can help with that. But like I said, we're covered in bacteria. So bacteria minding its own business in your urine does not need to be treated in postmenopausal women, only if you're having symptoms. Sometimes we'll give you some antibiotics if we're going to do some testing or something just to lower that bacterial count, just so we don't cause some irritation. Now, if you have symptoms, then we treat.
Great, thank you. Those are the questions that I've had come online. I don't know if you have any more in the audience.
Yeah, anyone else have?
Where's the cheapest places to get the pads that we don't wish?
I know. I don't. So I always tell people, look at Sam's Club's, Costco, because they'll get bulk pads. All the pad companies do competing coupons all the time. The different companies, Poise, Tenna, they do really aggressive advertising campaigns. So they're always running some coupon, something or another, and buy in bulk. But usually they will have some coupon thing going on. But yeah, no, and we wish insurance would cover it. Sometimes I write prescriptions for the pads. Every now and then I get lucky and Medicare or Medicaid will cover it, but most commercial insurance will not cover the cost of pads.
I find the best place is Walmart. I get the
Yeah,
pull-ups.
yep, those are really, Walmart does a good job. And
54 for $22.
Yeah, but really, that's why we do these talks because, all right, yes, insurance deductibles are expensive and we weigh the cost of wearing pads versus, all right, I gotta use my deductible if I need to have a procedure or my copay for medication. So a lot of times, like for example, estrogen, GoodRx, some of the cheapest estrogen prices. So insurance is often rude about vaginal estrogen. It can be like $90 to $200. With GoodRx, it's usually 25 to 35 bucks a tube at Fry's or Target. And so we usually in our office try and keep a good database on where the cheapest medication is, what's insurance is covering this last 6 months, what it's not, and what alternative we have. Because we offer you something, it needs to be realistic. Yes.
The two things that you just mentioned, what are those?
Which do?
The,
GoodRx?
yeah.
Okay,
I
good.
mean, and the product.
Estrogen cream. So vaginal estrogen can help prevent UTIs, and in some women it can really help with bladder control. GoodRx is a company, you've probably seen ads for it. All it does, it's not really a coupon. It tells you the cash pay cost of various drugs at all the different pharmacies. And what you don't realize is Walgreens charges a lot more for the same drug cash pay than Fry's or Target does. If you go on GoodRx, you can go to their website or they have an app for your phone. I keep the coupons in my office for my patients, so not everybody wants to do that. You type in your medication, it'll show you all the pharmacies in your area and what the cash pay cost is. And then you just print out the GoodRx coupon which just says, hey, I want to pay cash for this. I don't want to use my insurance. And surprisingly, a lot of medication is way cheaper that way. But you'll be surprised. Something will be 30 bucks at Fry's and it'll be $95 at Walgreens. They can set their own cash pay price. It's a market difference. So we pull up GoodRx all the time and just keep kind of a running tally of what costs what in the community so we can help people out. Yes.
One thing about that I found about GoodRx, because some people don't have internet access
Mhm.
or smartphone or know how to use it or whatever it is, but in my experience, Albertsons most Albertsons have a Costco there, and in their little displays on the counter, they have little yellow plastic
Yep, the little plastic cards.
that you can just take.
Yes, they do.
And you can use it like you do your discount card for groceries.
Yep. And if I give you a GoodRx coupon, it doesn't matter, say if it's for one medication. If it just says GoodRx on it, the pharmacist can use it to check the cost of all your medications. So the coupon isn't specific for the medication. Once you have a GoodRx coupon, you can keep reusing it for all medications. But they do. A lot of pharmacies will have that little plastic yellow card. The problem is, that's why we check in the office, because if Walgreens is going to be 3 times the cost of Fry's, we're going to tell you to go pick it up at Fry's.
Dr. Chesrow, I just want to thank you from our online audience that's been watching today for it. And we appreciate you being here and we look forward to having you back again. So
thank you so much. It was a really good time. Nice speaking with all of you.
I also just want to let you know that tomorrow we continue on with our Women's Health series, and we'll be discussing legal issues for women. So if you're interested in that presentation, please stay tuned on the YouTube channel that you're watching now. We'll be on at 2 p.m. with Chanel Schmitz, and she is with David Karp PLLC. So we look forward to seeing you then. Thank you.